Let me just. Sorry, hang on one second. I just want to pull something up. This was my daughter's apartment on Monday afternoon. So I just show that to you because that's why I'm late getting your exam. I haven't gotten your exams done just yet. I now have her two roommates and her 4 cats living with me. So it's just been a little bit crazy at the house. So I'm hoping to get your exams done today or tomorrow, probably tomorrow. All right, so we're going to be joined at 10 by former student Megan Linehan, who is an administrator with Genesis. I believe she's in Exeter now. So she has worked in I think 3, maybe 3 facilities at this point. So she's going to talk to you a little bit about what it's like being a long-term care administrator, kind of what it's really like working in long-term care. So let's kind of catch back up to where we were. We were talking about the continuum of long-term care. So if you have some sort of dependency, hopefully you can stay home and you can get home-based services. So it starts with, most of these quote services, right, scare quotes services, are provided by family and friends. So it's, going to pick up your neighbor and taking her to go shopping because she can't drive. That's an example of home and community-based services. You wouldn't think of it as, I am part of the long-term care system, but you are, right? If you're doing that kind of thing, if you have an elderly family member living in your house because they can't, they aren't safe living on their own anymore, you are part of the long-term care continuum. And informal care is probably the most important aspect of the long-term care continuum. Historically, it was pretty much the only part of the long-term care continuum, going back far enough. There have always been, like we talked about, almshouses and poorhouses historically. So those were the things that evolved into hospitals, right, over time as they became more specialized. So that's an example of primitive long-term care. So if you were unfortunate enough back 200 years ago to be poor and not have family to take care of you, then you probably got dumped into one of these poorhouses, which were probably pretty scary places to live out your days, especially if you were, had dementia or some sort of cognitive decline, or they had asylums, right, for people who had serious mental illness, and you did not want to get put in an asylum because they did terrible things, like they would sell admission to come see the crazy people in the asylum, and you'd get to make fun of the people with mental illness for a fee. The world has changed a lot in the last couple hundred years. Executions, just kind of not to go on for too long on this, but executions used to be public events. People would pack their picnics to come watch the execution, right? I can't even imagine that. Probably you can't either. Right? Things like bear baiting, they'd have a pit and they'd put a bear in it and they'd put a bunch of dogs in the pit and they'd watch to see the dogs tear the bear apart. Can you imagine PETA allowing you to do that? We still have some real retrograde pieces of work in our society that like to do dog fighting and things like that. But that was the same kind of mentality. So, people who would be willing to bring their kids in a picnic to watch an execution probably have no compulsion against going to visit the asylum on a Saturday afternoon for some entertainment. That's what it was. That was the world we lived in, right? So you did not want to if you had loved ones or family members, you were not going to let them go to a place like that. So it was only for the poor, right? So we have a long history of institutions that, perform some degree of care, right? Care, again, in scare quotes for those not watching at home, right? And I will tie that back to money and resources. When we were poor, that's all we could afford. As we became richer, our ability to care for each other and to care for those who are the most vulnerable in our society have evolved. And so our beliefs about what our responsibilities are have also evolved. So starting on the far left, community-based services, typically mostly informal, and we often don't even think of it as being part of this long-term care system. We progress to organizations providing formal support, right? So it might be a home health agency that sends in homemaker services or brings you meals, right? Charities, churches, and so forth, right? So then the formal organizations might be home health, providing services in the home and community-based environment. Then we kind of progress to non-residential day care programs like senior centers, which are not really, which are more kind of voluntary organizations, to adult daycare, where you actually have, they actually have a temporary or short-term custodial care. So you bring your adult parent, your elderly parent with or grandparent with dementia to the adult daycare. You check them in, and you know that they're going to be monitored and they're not going to be allowed to wander off into the city by themselves, right? To assisted living becoming much more common. Assisted living provides very basic level supports. So it's things like they'll cook for you, they'll do your laundry, but they typically don't do, and they may help you monitor, they may monitor your, they'll provide social programming, and they may provide some limited monitoring of medications, but typically your basic assisted living provides no medical care. So it may help with some of the IADLs and ADLs, things like maybe you need some care, help bathing, or you need some help, getting dressed. Varying levels of that, but a lot of it is just kind of providing you a safe environment that's monitored. So it's assisted living, it's not nursing care. And some of these places are gorgeous. Some of them are very simple and Spartan. Some of them are gorgeous. I had a student who did a internship at a high-end assisted living facility, and it was like being on a cruise ship. I mean, if you've ever been on a cruise ship, like they had a movie room with these huge recliners, and and you come down to the, and they had you'd come to the dining room, and they had you were waited on at your table, like you had your table, and they had waiters, and they'd bring you out, they'd bring you a menu, you could order off the menu. There was you go to the to the main atrium, and there was like a list of activities for the day that you could participate in. They had a bus to take you around. They had a bar, because these are adults, they're not children, like they're adults. They had a bar you could get booze at, have happy hour. It's a pretty cool place. I'm like, I'm ready to move in right now. Yeah, the thing was that a place like this though runs $7,000 a month, right? So $7,000 a month. So it's not for the poor, right? This is not a charity. And I chatted with the administrator, and I was like, so what if somebody runs out of money? They're like, well, we help them find new housing. In other words, they kick you out. If you can't pay, you're out, you're gone, right? So there are some assisted living facilities that will take Medicaid. It kind of varies state by state. And I guarantee you, if you're living in a Medicaid, in an assisted living that is running on Medicaid dollars, you are living a much more Spartan life than if you are living in a $7,000 facility. Then we move up to skilled nursing. So now you have some significant loss of abilities, right? So you might need help eating, particularly your ADLs probably are much more limited. So assisted living is good for the IADLs, right? The needs to function. Maybe you don't have the cognitive capacity to live on your own, but you can pretty much take care of yourself. Skilled nursing, you're moving into the zone of needing real care. You might be bed bound, right? You might need catheters, and so forth. Now, there is an interesting kind of blending of these organizations on the right side, the institutional side, and this is the Continuing Care Retirement Community, CCRC, Continuing Care Retirement Community. So Riverwoods, I don't know if you guys see that big new building as you go up 108 heading toward Dover from Durham. There's this kind of setback. It's called Riverwoods. It's it looks like an apartment complex. That is a CCRC, a Continuing Care Retirement Community. You move into Riverwoods while you are there's nothing wrong with you. You have to be in good health to move in. And it is basically, it is independent, what they call the first phase of the continuum of continuing care is independent living. So these are just very nice apartments. They tend to be smaller, and it's community living. So you have your own little apartment. I've never been in one, but I think like maybe a little kitchenette. They serve you, you can have meals in the dining room. So you kind of have choices. You have a lot of privacy. They'll do your laundry. They have maid service. You can make arrangements for different stuff. And you can live there. And then they provide programming, just like kind of as I was describing, that, there's an agenda for the day. They have recreation assistants that, come in and organize events for you. They do outings and stuff. And these are older folks who are still able to be active. Now, you move into the independent living. But what you do is you pay a fee. You pay a fee for these CCRCs. Typically what you do is you pay a large entry fee, and then you pay a monthly rent that is somewhat all inclusive. So again, it's like living at a resort. Food and a lot of stuff and programming and stuff is all kind of included. But while you're in the independent living, you can do whatever you want. You're pretty much just living in an apartment in this building, and they provide you a bunch of services. As you age, they wrap services around you. So as you age, as you cognitively decline, for example, and you can't do all your IADLs anymore, you move into their assisted living. And that may involve just staying in your original apartment, and they start kind of ramping up the care services to make sure you stay healthy and safe. So maybe you now need some help getting dressed or things like that. And then as you continue to decline, as we all inevitably do, because none of us are getting out of here alive, as you continue to decline, they have a skilled nursing portion of their complex where you can move up to skilled nursing and through end of life. So you never have to leave. If you buy into Riverwoods, you never have to leave. And you can. It's not, like a prison. It's a very, it's a pricey place to live. But you never have to leave. So they have the full continuum from independent living, kind of with a community. So it's kind of like living in a senior center, right? A very, very posh and nice senior center, up all the way through skilled nursing to end of life. Now, I want to say, and I'll probably misquote the numbers, but they're almost certainly higher. I met them when they were I met with the administrator when they were first opening about 5 years ago, and I want to say the entry fee was like $150,000 to move in, and then it was like $5,000 or $6,000 a month to live there. So you had to be able to prove, you had to cough up $150,000 to move in, and then you had to be able to prove that you would be able to pay that. You will have to have like $1 million in assets or something like that in order to prove that you can continue to pay the $5,000 or whatever it is per month through your likely end of life. So it's a gorgeous place. If you got a couple of $1 million, I highly recommend getting on the waiting list because it's completely full. Durham has more rich old folks than you can actually shake a stick at, apparently. I just had no idea that there were so many rich people in our community. And there's another one just like it down in Exeter, which I did know was super rich, but I didn't realize just how many rich people were up here. I'm keeping an eye on time because Megan's going to dial in here any minute. All right, so from there we could talk about kind of the models of support. So the column on the left is your home and community-based services. Column on your right is facility-based. So we're moving from left to right, going from home to facility. So what kind of long-term services and supports might you get? Kind of each column looks at. So where do you live? What services are provided? That was my alarm to pay attention to, Megan. So where do you live and so forth, all that. So I'm going to just kind of monitor here. So the community-based, right? The services might be personnel coming in to help you with daily living, right? Facility-based, it's going to be a higher level of care where they're going to help you with, managing medical tasks and so forth, right? So where do you live? Home-based, you're at your home or with a family member, or you're in a facility, if you're on the facility side, where are the services provided? Typically in the home, or you might go to an outpatient facility. And then who's being paid? Well, you know what? Sometimes family members can get paid for providing that care, but often it's just done for free as part of just your duties. On the other hand, if you're in an institution, right, the people employed by the institution are getting paid. I had an employee, a person. She was the director of under me of one of my sections when I lived in Louisiana. Her son was a telephone. What do you call it? Cell phone tower engineer. Like he'd climb these cell phones and cell phone towers and work on them. He fell from one of those and broke his back and had a whole slew of other serious injuries. And he's basically disabled for life. He was not a whole lot older than you guys. He's probably late 20s. So she retired to basically manage him at home, in order to keep him at home. And she was able to get payments for her from Medicaid and from the disability insurance to cover. Basically, she was getting sort of paid to basically be her his primary caregiver and care manager. So in some circumstances, family members can be included. Let me just check to see. Hey, Megan.
Good morning. I was just going to say, can you hear me? I accidentally muted myself.
How are you?
I'm good. How are you?
All right, hang on. I'm going to move you over so that the students can see you.
That's so exciting. You're back in person.
Yeah, and no mask. It's too bad you're stuck.
I know. I'm jealous. I'm in my office. I'd technically be okay, but I'm so used to it glued to my face.
So here's the students.
Hi, everybody. Oh, big class.
We're in New Hampshire Hall. You remember that? So I'm sorry. I have a owl. I probably could have set up, but I didn't. So so you're just gonna have to stuck looking at me. But bear in mind, they're sitting there listening to you. You're up on a big screen. Hey, all right. So hey, thanks for taking the time out. I just I already told them kind of briefly who you are. You're 2018 grad from HMP. You've been working in long-term care ever since. So I thought just a couple of questions for you so that they can think about, is this a field maybe that they'd want to get involved with? So I know this answer, but they don't. So what brought you to get involved in long-term care?
Yeah. So hello, students. This is 401, right?
This is 401.
Awesome.
So we have a whole mix we got a bunch of OT people, a bunch of nutritionists. I don't know, what else do we have in here? Some random other majors, but I'm struck by just how many, and a bunch of bioengineers.
Great.
Yeah.
That's great. Well, it's nice to see that there's some OT as well, because OT is obviously a huge piece of long-term care. Without OT, and happy OT, well, I know they're not OTs, but it's OT Specialist Month, so very exciting. We're celebrating that in our center here. But so hello, my name is Megan Linehan. Again, like he said, 18 grad. So I don't know if there's any HMP majors. I'm assuming there's a few in there.
There's like 6 or 7 in here. Yep.
Great. So I came in as a freshman, declared in HMP. So I remember 401 very clearly as a freshman, my fall semester year. So I jumped into long-term care actually when I was interviewing for my summer internship, my junior year as a HMP student. So I knew that I was going to be doing my internship, and I wanted to interview a lot with different organizations just to get the experience of interviewing. And I highly recommend it for anybody that's looking to do an internship, no matter what you're doing for your major. But I interviewed, with Dartmouth Hitchcock. I interviewed with, I believe it was Portsmouth Hospital, Elliott Hospital, so a bunch of different hospitals. But I had an interview with Sean Stevenson, who's no longer with Genesis Healthcare, but he was the senior vice president of operations at the time for Genesis Healthcare, which I'm sure some of you HMP students have heard of Genesis Healthcare, and maybe some OT as well. But we are one of the largest long-term care organizations in the country. And we're very well known in New Hampshire. That's our biggest market, actually, out of all of the states that we're in. So I interviewed with Sean, and just from the beginning, we just had a great relationship. And I think, I saw a lot of potential in growth in long-term care for myself in leadership and quick growth. So, I knew that I was a leader and wanted to become one sooner rather than later, instead of just taking, the time to work as, a lower level leader. So after interviewing with him, I had saw some serious opportunities for growth. And I did sign on with Genesis to do my internship back in, oh gosh, I don't know, was that
2017?
17?
Right?
Yeah, 2017.
18 grad.
So yeah, actually it'll be 5 years with the company this May. So it'll be my 5-year anniversary. So yeah, I started my internship, did that my summer year, and it was actually at Exeter Center, where I'm at now, and I'm the administrator here. But I wasn't always just at Exeter Center. I did my internship there for the summer, and then I stayed on as a part-time administrative assistant while I was finishing out school my senior year. So I did like 8 to 10 hours a week just to stay in the field, keep my feet wet. And once I was in my senior year, I reached out to Sean Stevenson and said, yeah, this is definitely what I want to do. And I'd like to continue doing it. And so he offered me an administrator in training position, which is also called AIT. We have an acronym for everything. So I did that, and in the state of New Hampshire, it's about a year long, and sometimes it can take a little bit more regarding, whether or not you're signing up for your boards or whatever the case may be. In some states it's different. In Massachusetts, it's 6 months. I'm not sure what Vermont is, but typically they're a year long. So I did that for a year, and then I became licensed. I helped the company out at a couple of centers that were struggling. They needed a change in leadership, and definitely I was the right candidate for them. So I helped by traveling to a few different centers. And then I landed back here as I bought a house in the Seacoast. So I've been here since last August, and that's kind of just an overview of how I got started.
Yeah, great. So I want to ask you to talk about, like, what is a nursing home from your perspective, maybe, and what do people not understand? Like, what did you maybe not understand before you got there about how they work and who's there and all about that? Yeah.
So, nursing homes are so diverse. Every nursing home that you look at can be completely different, really. When I know a lot of the stigma is, a nursing home is all elderly patients. They're 80 years old, 90 plus, and that's what the building looks at. And, it's a slow moving building, and that's really not the case. So every nursing home, and we say skilled nursing facility, has a different population. So here at my facility, this is a smaller facility, 81 beds. Typically, the average facility is around 100 beds, and then anything over 100 is considered a bigger facility. So mine is considered technically small as 81 beds. So 27% of my patients here are skilled. So that means that they came in for occupational therapy, physical therapy, speech therapy. So we have all three disciplines of therapy. And whether they came in skilled or they're a long-term care patient that needed skilled services. So whether that is a patient that had a choking episode or an issue with swallowing and they needed to see a speech therapist. So they've been working with our speech therapist in the facility to get those services. Or it could be a 56-year-old multiple sclerosis patient who needs assistance with moving his hands, and that we see that a lot, and he gets some OT assistance. Or whether it is a 90-year-old patient that fell and broke their hip and came into the facility and they need help with PT to get stronger to be able to either go home, and that's the goal, or maybe the family can assist in what they need and they need to keep them here long-term care. So that's what we see here. So we have a fairly high skilled mix in my facility, but in some facilities you see they have like memory support programs. So that's your dementia, Alzheimer's patients that need a higher level of care, whether it's, they're wandering throughout the facility, they need a lot more activities, they need scheduled programming. So I've been at a few facilities that did have those memory support programs. And then we have one of our centers has a mental health and recovery unit. So that's in Hampton. So, a lot of what we're seeing in healthcare right now, and I'm sure even the hospitals will say this, is that long gone are the days of, 85-year-old patients that broke their hip at home and they came into our facility to get skilled services. Those patients are now going home. They're getting their surgery in the hospital and they go straight home and they get home healthcare services to help get them stronger. What we're seeing now in the shift in healthcare, and especially with the pandemic, that was a huge switch, is we're seeing a lot of depression, major depression. We're seeing a lot of mental health concerns. We're seeing a lot of alcoholics, a lot of people that do need alcoholic recovery or drug rehab, drug recovery. And that's difficult, right? We all know that the staffing challenges in all of our facilities, whether it's nursing homes, hospitals, you name it, we're all struggling to find staff. And obviously with those patients, you need a lot more care. So you need more staff. So it's a difficult transition right now, but so that's kind of, like I said, every nursing home is different. They have their niche. Our facility, we really specialize in IV therapy. So, our nursing staff are highly competencies in providing IV care in our facility, which is very helpful for a lot of the patients that come in that are very dehydrated and need skilled IV therapy. Does that answer your question?
Yeah, that's great. So one of the things that surprised me, when I first started at UNH, and I, because I had spent my whole career in acute care, so I knew very little about long-term care. But one of the things that surprised me, talking to like Sean, talking to the folks like Tom LaValle, Jason's dad,
Yep.
is just how, because I had a vision of it being custodial, kind of what you're saying, like relatively low acuity care, and primarily custodial. But that's really changed a lot, right? So
absolutely, yeah.
You have a lot of short-term stays as well. Maybe you
Oh
could talk
yeah,
to that.
so again, like I said, 27% of my my facility right now is skilled mix. So that's whether they came in on their Medicare A benefit or they came in on a VA veterans benefit through Medicare. And I won't go into the specifics of that, or maybe they came in on their managed plan and they came in to get those skilled services. But typically nursing homes before, in the past, the skilled mix was usually around 10%. So 27% is very high. So we are seeing a lot of skilled patients that need therapy and services. And Yeah, it's not just custodial care. And custodial care is a lot different than what it used to be in the past. It is a lot higher acuity levels. Like we do have a lot of IVs, and with COVID, you have a COVID outbreak, we're providing IVs, therapies of monoclonal antibodies to treat COVID patients. So that was a lot. Obviously, thank God we're not in an outbreak right now, but when we had 12 patients that were receiving IVs for monoclonal antibodies, which that's a lot of work for the nursing staff here. And when you look at the hospital, their staff to patient ratios, typically are 1-to-1, 2 patients to 1 staff, maybe 3 to 1 staff. And here in our facilities, what they normally have been is 1-to-15. And on our skilled unit, we're seeing around 1-to-13, which doesn't sound terrible, but when you add in all of those IVs, you add in the wound care that we do. I missed that piece. That's a huge piece of what we do here in nursing homes is we have wound vacs. Someone comes in and they've been at home for 2 years and no one's been caring for them, and they have these large gaping wounds and no one has treated them for years. So we get them here and we have to go through all of that treatment, and we do heal the wounds, which is fantastic, but it takes a very, very long time to heal those wounds. So yeah, it is the acuity levels are high for sure.
And I think, we've been talking about the evolution of the care system, and, nursing home, like assisted living wasn't really a thing 20 or 30 years ago, right?
Yeah.
So what we've seen, I think, and you could talk to this more, is kind of a specialization. Like the assisted living are kind of taking the lower acuity patients.
Absolutely.
And so what's left in the skilled facilities is a much higher level of care.
And what's difficult specifically in New Hampshire, and even just the Seacoast too, if we're looking at the Seacoast, is that there are a lot of options for assisted living. One, they don't have beds. So no one has beds available. And if you do have beds available, you don't have the staff to staff those beds. And second, there are not enough Medicaid accepting assisted livings in our state. So what I mean by that is, you have a patient that is in our facility, we accept Medicaid, and they come in, they need custodial care, but maybe they're at a higher level. So, they're not incontinent, they don't need incontinence care, or, they aren't a fall risk really, or they're able to manage some of their medications. So those people really aren't appropriate for our facility. And they really do need, more of an assisted living level of care. So if they go to those assisted livings, the problem is that Medicaid is not accepted at most assisted livings. They're private pay. And when I say private pay, you're looking at $12,000, $11,000 a month for care, which is obviously a lot of money, and most of the people in our state cannot afford that. So it makes it very challenging for a lot of families.
Yeah. Can you talk to reimbursement briefly? What's your case mix?
Yeah.
And don't give me anything that's inappropriate to be shared out into the world. Give me a rough.
No, I won't. And just a basic overview. So Medicaid is pretty much, I'd say 95%, 96% of what the patients that you see in a long-term care facility when they're long-term care. So that's the payment source that you have in your facilities. And then, you do have a few private pay patients in some of the facilities, and it depends on where you are in the market, right? So when I was up in Wolfboro, I did have a lot of private pay patients because of the market. It's a more wealthy area. Exeter, we have a few. Portsmouth, I had a few more too. So it depends on where geographically you are in the market. So when you have Medicaid patients, and again, like you said, it has always been viewed as custodial care. And yes, I'm not going to lie, there are some patients that are pretty independent and, just need assistance with medication management for the most part. And that is essentially custodial care. But, you have these patients that are are 2-person lifts. So what that means is that it takes 2 people to get them up out of bed with a, some facilities say Hoyer lifts, but we say total lift. So it's a lift machine that gets them up out of bed and into their chair for the day. And then you have to get them up and put them, down for lunch and back and forth and back and forth. And that takes a long time. So the reimbursement rates for long-term care are just, it's really disheartening, unfortunately. And New Hampshire Healthcare Association has really been trying to advocate on our behalf that, through the pandemic, the cost to our facilities has just been overwhelming. Really, it's hard for, most mom and pops have had to shut down, nursing homes over the past 2 years. Thankfully, we have a large corporation that has been able to support us. But the medication or the Medicaid reimbursement rates are very, very low. So we don't get the support financially that we need to be able to staff more to take care of our patients. Medicare rates are pretty good. We're seeing, they could absolutely be better, and they could be, increased a lot. I think our biggest challenge is what we're seeing specifically in this market is managed care. The authorization process is very, very difficult to get authorizations. You have patients that are in the hospital that need skilled therapy, and the hospitals want to get them out of their beds because they're taking up beds that they could be using for other patients, but yet they sit in that hospital bed waiting for authorization from that insurance company for 2 to 3 days. And sometimes they get denied after that. Most of the times they do. So when they get denied and they have nowhere to go, that's what's struggling, because obviously we can't take patients that don't have a payer source. So that's been something that we've really been struggling with lately, is the managed care piece. Yeah.
Okay. So we've talked about, I want to go over something you said, like,
yeah,
you go into the hospital, let's say you break your hip, you're an older person, you break your hip, you go into the hospital, you get your surgery, and then you get discharged to a nursing home or transferred to a nursing home, and you're on that Medicare A benefit. So that's what you were talking about.
Yep.
And most likely you won't be there. You'll be there for a couple of weeks getting therapy, and then you'll get discharged to home. So you're short stay there.
Yep.
But if you're a long-term stay, you're not going to be on Medicare. You're going to be on Medicaid
Right.
once you burn through.
Yeah. So typically what we see is, someone's coming in, they fell at home, need that skilled therapy. We try to push as many days as we can get out of the insurance company if they're managed. If they're Medicare, they have those days. But it's very hard because you have to prove to the insurance company that they need to be there, right? So, and there's also a skilled need as well. So it's not just therapy, but you have skilled services for nursing. And that's really what they're focusing on the most now. So we need to capture whether they need wound care management. We need to capture whether they need IV therapy, like I said before. All of those things, or maybe it's a high cost drug. Maybe they're a chemotherapy patient that is here to receive their chemotherapy treatment. They're going out, they're staying here, they're going out to their appointments and getting that and then coming back. Or we have a lot of dialysis patients as well too. So but we have those conversations the second they come in, within the first 72 hours, they come into our facility for skilled therapy. We really go in as an interdisciplinary team with the family and the patient to say, what are your goals? What is your baseline, and where do you want to be? And if there's a question of whether or not they can be able to take, mom home, then we start that process for Medicaid, or at least discussing with the family, this is what you would need to start the Medicaid application process, so we can get ahead of it when they get here.
How much does Medicaid reimburse on a daily? What's the daily rate for Medicaid these days, roughly?
Roughly, not enough, I can tell you.
Yeah,
that.
right.
I can look up the exact numbers for you, but it's like $300 a day. It's not, it's definitely not appropriate. So, it's almost like we're losing money, really.
Right. So for $300 a day, you've got to provide them a place to live, food, and then all this skilled care. So it's got to that money's got to cover the expense of running the facility and all the expenses, right? So so when you're running on, 90+% Medicaid reimbursement, that's a tight That's budgetarily
It's
really,
really tough. Yes.
really
Yeah.
tough. Yeah. Okay. Hey, so you've been having some fun for the last 2 years.
I
What's it been
have.
like? I mean, like, so you went in prior to COVID. What's it been like leading your organization through that?
Yeah. So just a little background. Ironically, I started in my first building. I mean, I was covering a maternity leave as a licensed administrator, but it really wasn't my building, shall we say. I covered the operations for a few months, but my first building, my very own first building, I got the keys handed to me on March 5th, 2020. So literally the first day of COVID.
Yeah.
So, and that was before masks. We just knew that the coronavirus was in Italy at that point and it was coming to America. So, yeah, it was crazy. I mean, you look at nursing homes before, and families would just come in and out and in and out all day. And patients would go out, or residents, long-term care residents would go out with their families to lunch, or maybe they took a leave of absence and they, went camping with their family for the weekend. Maybe some of your family members or grandma and grandpa live in a nursing home. I mean, there were no restrictions. They came and go as they please. So that first week was just a whirlwind. We closed our doors to all of our family members, and this went on for months, almost a year. We had to close our doors, close the windows, and essentially completely isolate these residents from everyone that was important to them. And needless to say, there are some residents that don't have family, and that's really tough. And our staff are their family. So when we come in every day, we're the only people they see. But yeah, they couldn't even do communal activities. They couldn't have a concert. It was, you're in your room, we'll bring around, maybe a sheet of bingo and we can do it through the projector system, but they were completely isolated. And and that's just the resident side. So managing as an administrator, I had a lot of grievances. I mean, when we see grievances, we say, issues or concerns that the families of the patients bring up, and there's a formal grievance policy and process that I have to do to make sure that their grievances are heard and followed up on, and that there's a resolution. But families were scared, patients were scared, and most of all our staff. And I think that was the most difficult part, is that we saw people just leave in droves, healthcare as a whole and long-term care especially. Our rates are nowhere near where they need to be for us to be able to pay our staff. And we pay very well at Genesis Healthcare, very well. But we're fortunate enough to have a big company to be able to do so. But there was no childcare for my staff. So many of my staff members are young single mothers, whether they're in their early 20s or some of them are in their late teens, and they had no healthcare or childcare for their children, which means they had no way of getting into work. And obviously we couldn't let them bring in their kids into the facility if we couldn't even have family members there. So it's very difficult. I would say back in the first year and a half of COVID, I would say probably 85% of my daily jobs or job duties as an administrator had to deal with COVID. And it was just a whole different ballgame before. And now, thankfully, it's dropped down a little bit. I think probably we're at 50%, but it's still 50% of my daily job duties have to deal with some sort of policy or procedure or something that has to do with COVID-19. So it's the new norm. We're getting used to it. We're getting, but vaccinations, thank God we have them. It's a lot of work though. We do our own vaccine clinics here at the facility, which we're blessed to be able to do. But there's a lot of documenting, a lot of communication to the State Department of Public Health. We do a lot of calls with them, and it's just managing, and documentation is huge, but it's a lot. Yeah. I don't know if there's any specific questions you have on it, but.
Yeah, no, I just wanted to give a flavor. Really challenging time. So questions for you guys? Any questions for Megan? Want to know something about being a long-term care administrator, being a young, fast moving, no? All right. Well, hey, so what's your future? What do you see? What's 5 years from now?
Oh, 5 years from now, it's funny. People are like, wait, how young are you? And I don't tell them. I don't tell them how old I am. I keep that out of it on purpose. But I see our corporate leaders come into the facilities, and it's great to have those, and it's nice to be able to climb the ladder, but I just truly, my heart and my passion is truly with the residents. And I think it would be very difficult for me right now to say I would ever leave at a center level, and I'm sure one day I will. It's exhausting, it really is. But my passion is definitely with the population and with the residents. So whether it's going up to a regional executive director position at some point in my career, which I'm sure I will want to do that, you lose the day-to-day experience with the patients and the residents and the staff too. So I think for now I'm comfortable. I love leading at a center level, and I love that daily interaction and being able to be in the center every day. I'm not a work from home person whatsoever. I do not want to work from home at all. And that's a lot of what our corporate leaders are doing, is that they're working from home. So I love the daily interaction, and I love being with people. So I think I'm good for right now, but one day, maybe getting higher in the regional positions would be good.
Awesome. Hey, Megan, thanks so much for taking the time to say hi.
Yeah,
And
absolutely.
hopefully next year I can have you in person.
Yeah, absolutely. And good luck.
All right. Thanks.
All right.
Talk soon.
Thank you. Bye-bye.
All right. Let me just, so just getting reset here. All right. So Megan's really great. If any of you are interested in meeting Megan or having a chat with her about opportunities in long-term care, I'm sure she'd be more than happy to visit with you at some point. So let me, just shoot me a note if you'd like to meet her. She probably, you can, I think the facilities are open and you can go back and visit if you wanted to see a facility now. So thoughts, any impressions from hearing what her career is like and what her duties are like? Would you want to do that? Any of you thinking about it? Yeah. Okay, great. It's a good field. It's a good field. It's well compensated, at that level. So a couple of things I wanted to highlight that she said. One was, she said her facility is like 95% Medicaid. Genesis tends to have a higher, we've talked about this in class, case mix, which is, the percent of people who take Medicaid versus Medicare versus private insurance versus private pay, right? That's what we talk when we're talking about case mix. We're talking about the mix of insurers payer mix, not case mix, but payer mix. When we're talking about payers and the mix of payers. So a hospital the only hospital I'm aware of that runs at over 80% Medicaid is Boston Medical Center, which is used to be Boston City Hospital. Its mission is to take care of the poor and indigent, but Exeter Hospital takes maybe 15% Medicaid, right? So most hospitals take some tiny fraction of Medicaid. And the reason is Medicaid is a terrible payer, right? It is super low. It is not enough money to run. Most organizations can't function on that level of reimbursement. Genesis kind of specializes in basically Genesis takes almost anybody. I don't want to speak out of turn, but Genesis, what's remarkable about Genesis is they will take more Medicaid patients. So it's a for-profit company, but it provides services that a lot of private facilities would just turn you away. They're like, no, we can't take any more Medicaid patients. And Genesis pretty much makes it, opens their doors to almost everybody. So that's one of the more remarkable things about Genesis is, and I suspect part of why they're struggling financially, and that's not a secret. I mean, that you can just look on the news. They're struggling financially in part because they take the poorest and the sickest patients. So it's a really interesting thing. Like we talk a lot about not-for-profit entities, and we're like, oh yeah, not-for-profit's great. It is great, but Riverwoods is a not-for-profit entity. It costs whatever it is now, it's probably way more than that, $150,000 just to get in the door, and $5,000 or $7,000 a month to live there, right? They're not taking any Medicaid. No Medicaid people live at Riverwoods. Like that's not a thing. So, and they're a nonprofit, whereas Genesis is a for-profit, and you heard Megan just say 90-something% of her patients are Medicaid beneficiaries. So who's doing the charitable work? It's an interesting thing, right? So the Genesis business model is built for them to be able to do that. So it's something interesting to think about. All right, so I want to move forward. So we talked about community-based care, and I've mentioned this organization before, Krempel Center. This is an organization I'm on the board of, work with. They do amazing stuff. OT folks, you'll be almost certainly be spending some time there. Krempel's is really built around an OT. The modern Krempel's is really built around an OT model. I mean, any of you OT folks had Barb White as a professor yet? No. Not going to admit it if you did. Oh, no. Okay. So Barb is a colleague of mine. She's an OT professor, and she's been on the board for, I don't know, like a dozen years or something like that. So she is, a lot of her leadership is really reflected in the way that the program operates. They do beautiful work. Really just can't say enough about the impact they have when you go and you listen to folks. So imagine right now you got in a car accident, right? And we have young people your age going to get services at Krempel's. You get in a car accident and you lose a significant portion of your cognitive ability, right? You can't remember things anymore. Your memory, your short-term memory is damaged. And so you can't study anymore. So you have to drop out of UNH. And you know what? I'm probably never going back to college. I'm never going to get that degree in biomedical engineering because I can't remember the stuff anymore, right? Not only that, I probably can't drive. I can't, all these plans I had for my life are now over because I was in a car accident and I got a head injury. Would be pretty damn depressing, right? And so people who have suffered those kinds of losses come to Krempel's, and there's a community there, and they do some therapy, but more importantly, it is a community of people who understand what you're going through. Because if you saw most of these folks, some of them you could tell something has happened to them. But if you saw most of these folks just walking down the street, you'd have no idea that they've had a major trauma and that they suffer from all sorts of challenges as a result. So it's really so it's an organization that's kind and gentle and provides a place where these people can come together and people understand them. We call it the invisible injury because you don't, like I said, most of them, if you see them on the street, they look just like you can't see, that something bad has happened to them. If they had lost a leg or if they were in a wheelchair, you'd be like, oh, wow, really sorry about that. Instead, they just show up maybe at your store or at your restaurant and they're confused and, you don't know what's going on. Are they on drugs? Or are they just being jerks or whatever, right? And so it's very hard for them. And so this Krempel's provides a place where everybody kind of understands who they are and what they're going through. So it's a really beautiful organization. It is outpatient. It's 3 days a week. And so they come in, they do a morning meeting, they talk to each other, give each other updates, and then they have programming throughout the course of the day. Some of it is working on trying to improve memory. Some of it is just, community building, stuff to do, and just to have a community to be a part of. And you listen to them talk about the impact on their lives. And, many of them are like, I wouldn't I wouldn't have survived without this support. So there's a lot of so I talked to this because I happen to be involved in it. My colleague Barb White got me involved in it. I'm lucky enough not to have family members who have that would need these kind of services, but most of the people on the board either that I serve with are either have had a brain injury themselves, or they have family members that have suffered from it. So this is a great not-for-profit entity, right? That really does have a charitable heart to it. It's not just servicing rich people. So rich people need a place to live too, right? So we don't want to be too mean about it, but so Krempels is an example of kind of a community-based service, right? So these people come for services and then they go home at the end of the day. It's not an institution. So I've been using this idea, Amartya Sen, talking about capabilities, and so capability as freedom was kind of his thing, right? And so I wanted to kind of circle back to this idea of justice. So what does the just society do? I've talked a little bit about this, but it creates conditions that maximize freedom, right? Gives us the ability to be our own people, to have autonomy, to be able to pursue the things we want to pursue. It minimizes, right? The good society doesn't get in your way from doing the things you want to do, right? Whether that is, expressing, and that is expressing your true self and whatever, loving who you want to love, being who you want to be, right? If you want to be an OT, you can be an OT if you can do it, right? You can be a biomed. Nobody's going to tell you, no, you can't do that because you're whatever, right? That's a good society. So how do institutions of care fit in? And I would say it's kind of a tragic history, and I've already alluded to it a little bit. How many of you guys have seen this movie, One Flew Over the Cuckoo's Nest? It's kind of old now. Yeah, you've seen it? All right. Tell me about, you remember, so this is Jack Nicholson, right? Give me the 5-second, what's the basic idea of the story? You guys remember? Yeah, don't give away the end, but yeah.
Yeah, more or less the same thing, but he kind of organizes people in the institution against nurse practitioners, like the head nurse.
Yeah.
Kind of goes in, kind of overthrows the power balance, kind of upsets things.
Yeah, and the power balance doesn't like that, right? So it's so that's a basic idea, right? So Nicholson is playing a criminal who pleads insanity in order to get out of actually going to jail. And so they send him, he thinks he's just going to walk, but he winds up getting now sent to a locked psychiatric ward. And he discovers what it's like to live in a psychiatric ward. And most of the people, but not all of the people are genuinely mentally ill. And he rails against the institution. So this is a 1975 book, film based on a 1962 book. I do recommend it. It's worth watching because it had a profound impact on our thinking as a society. We were already kind of moving in this direction of what we call deinstitutionalization, which we've talked a little bit about. But it used to be, again, because we were poor as a society, relatively speaking, because we were poor as a society, we didn't have the ability to treat people on an outpatient basis, right? Institutionalizing people, there are economies of scale, right? If you can bring a bunch of people together that need a particular kind of service, it's actually can be cheaper to do them all in one place. You can provide all the services in one place. And so that's what we did because we were relatively, as a society, we meaning, as a society, relatively poor, right? And so asylums, and institutionalized mental health was a cheaper way to deliver care. But it can be a dehumanizing experience. So this is a very good demonstration of a concept called a total institution. And in particular, the movie does a great way of showing how dehumanizing a total institution is. So let me share with you the kind of definition of this. So a total institution is a place where a large number of like-situated people are basically cut off from wider society for a long period of time, and they are and all aspects of their life are conducted kind of at the same time, in the same place, under the same authority. So if you are in Jack Nicholson's or in the One Flew Over the Cuckoo's Nest version of a locked psychiatric hospital, and bear in mind, it's a movie, right? Not everything was that bad, but some were really that bad or worse. Basically, you get woken up, everybody wakes up at the same time. Everybody gets dressed at the same time. Everybody eats breakfast at the same time. Everybody then goes to play bingo at the same time. Everybody goes and has lunch at the same time. Everybody now goes and watch movie at the same time. And oh, by the way, you don't get to pick the movie, the institution picks the movie. Everybody goes and does, now it's time to go outside and walk. Now it's time to go to dinner. Now it's time to do, now it's time for quiet reading. Now it's time to go to bed. Everybody go brush your teeth now. Imagine having zero autonomy, right? I don't want to go out to walk, I want to stay in and read my book. No, you're going to go walk because we're all walking right now. That's total institution, right? Imagine that's not just like for a day, but that's for a year or years or for the rest of your life, looking at that and how awful that would be. So total institutions, right? So this is a theory that came out of the 60s around the same time. There are a reason for this, when we've had these facilities, it's cheaper and easier for the institution to run services if everybody's doing everything at the same time and everybody's doing the same thing at the same time. You can optimize your staffing so that you have the least amount of staffing, but that is really focused on providing care from the institution's perspective, what's best for the institution, rather than what we call a patient-centered perspective about what's best for the patient. And so nursing homes were often run on kind of a total institution, model, not because because the providers were mean necessarily, though some of them were, but because it was the most efficient way to provide care. So some examples of total institutions based on how the person who's being institutionalized is perceived. So for example, a person felt to be both incapable and harmless might go into a nursing home, right? And nursing homes today are not total institutions, but they would have been, were much more so back once upon a time. Persons felt incapable of looking after themselves and a threat to a community, maybe an unintended one. So we've talked about leprosy, TB used to be, they had hospitals where you get sent, mental hospitals, so forth, right? So you can't take care of yourself, and you are a danger to society and maybe to yourself, but you're not a bad person, you're just sick. Prisons are a great example of a total institution. If you listen to the narratives of people who have been in prison for extended periods of time, they will tell you the worst part about prison, a lot of the worst part is the lack of ability to have any autonomy, to have any control over your life. The institution controls everything about your life, right? I went through basic training. It's about the closest I've ever been to into a total institution. I will tell you, no desire to repeat that experience, right? You wake up, drill sergeant comes in at 4:30, kicks a trash can down the middle between all your bunks and starts screaming at you to get up. Everybody gets up at 4 because it's 4:30. We go and we have 10 minutes to get cleaned up and get down into formations. We march to the chow hall to eat. Then we go, or to go do exercise, and then we come back, get changed. You got 5 minutes to get changed, out and so forth. There's a reason for it. basic training is a total institution on purpose because it does want to remove your individual identity, right? The purpose of basic training and the reason it is run the way it is run is to kind of crush you into compliance, if you will, right? To make you identify with the military and not with your identity as an individual. And then we have some other ones that are interesting and voluntary, such as religious monasteries in all different traditions have these experiences where, again, like the military, the reason they're run the way they're run is to force you to give up your ego, right? And so, you know, you could leave a monastery, but the reason it's run as an institution is to kind of force you to give up your own individual identity. But most people don't want to give up their individual identity. It's a brutal thing to do to people. So those are some examples. So historically, so we have some, so historically, a lot of our mental health institutions were run like One Flew Over the Cuckoo's Nest. It was a reasonably, if slightly exaggerated, a reasonably good example of a low quality facility. And so as we became wealthier through the 60s and 70s as a society, we really started to become wealthy. We started looking at our institutions, and we had, you know, institutions for people with intellectual disability. We had, you know, that were quite cruel. And one of them is actually that is written about quite frequently, is actually down in Waltham, and it was quite a cruel place. And they ran medical experiments on the children that were housed there through the 80s and into the 90s. Like, we're not talking ancient history here. We're talking just a few years before many of you were born. There were people doing medical experiments without permission on kids with intellectual disabilities. So kids with Down syndrome who parents didn't think they could take in Waltham, not in some, you know, crazy place that, you know, we all might look down at. And so what kind of, you know, cultural, so art does a great job of moving culture and moving our assumptions. And so art like One Flew Over the Cuckoo's Nest helps to shift the way we think about what we're doing as a society. And people started saying, we should not be doing this. This is cruel to put people in an institution and take away their identity, right? And so we've got to have a better way. And so there was a movement that's referred to as deinstitutionalization. So we took all these mentally ill people who we had confined into these, you know, dehumanizing total institutions, and we said, let's get them out. Let's get as many of them out as we can. And so, and I would say the pendulum has swung, as it often does in social change, from being way over here with we're institutionalizing anybody and everybody that has any sort of mental illness to all the way over here to being like, everybody out, get out, everybody out. And it happened so fast that we didn't really build the community-based services that these people needed before we kicked them out of the institutions. And so this was happening through the 80s and 90s. Most people who, if you talk to a police officer, if you talk to sheriff's departments, so it's often the sheriff's departments often run your local jails and sometimes prisons as well. So a jail is typically, the difference between jail and prison is jail is short-term and prison is long-term. So typically in the language of criminal justice, a jail is typically referred to as a short-term stay, so less than a year. So if you got 90 days for, I don't know, getting in a fight or something like that, then you'd probably go to the county jail. But if you murdered somebody and you got life in prison, life sentence, you would go to a prison, which is a permanent facility, right? So you wouldn't go, like, you wouldn't get locked up at the Stratford County Jail. You'd get locked up wherever, I don't know, I assume we have probably one in Concord. And I know we have like a federal prison up in Berlin, for example. But if you talk to people who work in the criminal justice world, they'll tell you most of the people who are in jails have mental illness, right, of some sort. Almost everybody who's homeless has mental illness. People go through stints of homelessness because bad luck, but people who are long-term homeless almost always have mental illness. And oh, by the way, almost everybody who is long-term homeless also has an addiction issue, because the way that you treat your mental illness on the street is you take drugs. So a lot of people, so many of the people who are in prison have serious mental illness. The problem is prisons are not a great place to treat mental illness. Jails are not a great place to treat mental illness. The people who run our jails and prisons are not mental health counselors, right? And so it's a further problem. So we went from 60s, and prior, to being institutionalized. Everybody who's got any sort of intellectual disability, any sort of mental health disability, we're going to institutionalize them, to a huge swing in the 80s to deinstitutionalization. And the big problem with that was we didn't get ahead of that wave of people being kicked out of institutions where they'd maybe lived for years. And they exited and they immediately became homeless. They immediately got into altercations, and they wound up either in jail or in homeless encampments. And we have a real problem with psychiatric beds in New Hampshire in particular. We are very, very bad. So if you have somebody who, like my friend Eric, who I talked about last class, has a major psychiatric episode, he will, if he is in New Hampshire, he could potentially wind up being, he'll get taken by the police to a, and he has been taken by the police to the local emergency department. They'll try to restrain him. They'll figure out, okay, oh, he's in his case, they probably know him by now because he's, a member of the community for a long time. But if it's a new person being diagnosed for the first time with major mental illness, they'll try to figure out the basic diagnosis, and they'll say, oh, this is a person that has a mental illness. We need to get him into the state hospital in Concord, which is our inpatient psychiatric facility. But the problem is there might be a 30-day backup for a bed or a 2-week backup for a bed, right? In which case these people wind up staying in the emergency department, which is, and I think we've talked about this, is not a place, it's not a good place to treat people. So the state is grossly understaffed, underbedded for inpatient facilities, in part because of that deinstitutionalization wave that went through as we shut all these abilities down, these capabilities down. We also don't have enough outpatient care to care for the people who need the care. If you're looking for, I was talking to a colleague, who has a child with some serious mental illness issues, self-harm kind of stuff, and she needed to be hospitalized. He had to take her, the facility, they were basically told she needs to be hospitalized immediately. They wound up having to fly to LA to get her hospitalized because there were no beds closer that could take care of her. So we have a lot of problems in terms of, there are people that need institutional care and can't function on an outpatient basis. So on the one hand, back in the 70s, we said, what have we done? We've been doing that. We have this, there's all these terrible places where we have all these people that are being, treated badly because we have them in total institutions and they just need some care. They don't need to be in an institution. And so we booted them all out, but we didn't leave enough space for the people who really, really need it. So what happens when we don't have the institutional the space in our institutions for the people who really need it. We wind up with street drug scenes like this. So you can see the woman in the wheelchair has got her pants down and she's shooting up with heroin, presumably. And the woman over here, you can see it, she's looking in it's a little hard, it's a little darker. She's looking in a mirror while she shoots up into her neck, right? And this is in San Francisco, at a outdoor site called a linkage site. This was a couple of weeks ago. This is not like history. This is like, it's happening right now. Like this picture was taken back in January. San Francisco has some of the worst homelessness in the country. It's one of the richest cities in the country. It has some of the worst homelessness in the country, in my opinion, mostly because it's got bad policies. But this is a policy. They set up a site that was supposed to help people get linked, who needed it, get linked with outpatient services so that they can get clean. Instead, what it's turned into is basically an open air drug market. And so these are pictures that were taken by an investigative reporter showing what's actually happening there. So these people are homeless, addicted, almost certainly mentally ill. They belong in an institution, most likely, at least for a short term, right? And we're failing them as a society. We're not providing the care that they need, right? Because we said, oh, you know, one flew over the cuckoo's nest. We know what happens in a inpatient psychiatric facility. Well, the problem is you err too far in the other direction and you wind up with this, right? Now, all is not bad. The Edgewood Center is a nursing home in Portsmouth. It's run by a former a grad of the HMP program named Tricia Cummings. She is the best person in the whole world, you know, and she just loves her residents. I've visited there a whole bunch of times with her. I tell you, if I ever have to get put in a nursing home, I want to go to Edgewood and have Tricia take care of me because she's the best person. You know, she just loves caring for people. So this is a beautiful facility. It's a nursing home, right? And so once upon a time, nursing homes were much more total institutions, but there's been a real movement in the long-term care world, and highlighted by a guy named, especially by a guy named Bill Thomas, who's a family medicine doc by training, kind of stumbled into long-term care. He got hired in one of his early jobs. He got hired to be the medical director. So every nursing home has to have a relationship with a provider of some sort to kind of oversee the medical care being provided to the patient. So he got hired as a medical director and he started looking at, and he's got a beautiful book. I can find the reference for it. If you're interested in long-term care, he writes some beautiful books about aging and about caring for people in nursing homes and creating a better alternative. And so he's developed this idea called the Eden alternative. And so he started saying stuff like this, you know, in this traditional nursing home, he's like, people need connection. Let's get some pets, right, for the building. So he started bringing, so working with the administrator, working with, you know, legal, they brought in like dogs to live at the facility. And so the dogs kind of wander through the facility and the patients get to pet the dogs and the dogs kind of wander in and out of the patient rooms. And he said, you know what else we can, let's get patients some parakeets. So a lot of patients have parakeets are quick and easy to take care of. I mean, just give them in a cage and it gives them a sense of care, of being able to care and to love on something, right? And so he's got all these ideas that if you go to a nursing home that runs under this Eden alternative, these are the values that they try to run their nursing home on. All right, I got 2 minutes and 2 quick slides. We have a problem. In 1960, this is what our population looked like. So at the top, so left side, at the top, millions of people 85 and older, tiny, tiny number, right? Millions of people, coming up through the pipeline, very wide. So we have very wide base, a lot of young people, not very many old people. That's when we said, oh, you know what we can do? We can have Medicare, right? And the young people can pay for the old people's Medicare. What are we going to look like in 40 years? It's going to look like something like this, basically it's going to be as many old people as there are young people. And we're rapidly heading in that direction. So that's a problem in terms of paying for long-term care. Where's that money going to come from? Well, it used to be there were so few old people, you know, we got all pitch in a couple of cents and we could take care of them. Today, it's already like, you know, 3 working age people for every 1 old person, and it's just going to get worse. So the main problem that we face, I think, in terms of long-term care is, number one, long-term care insurance just doesn't work. We went through this death spiral thing where it got too expensive. People said, forget about it. I don't have it. I'm 50 and I don't have it. You know, I'm just counting on, hopefully I'll just have a stroke and die like that and not have to go into, you know, into care, right? Medicaid, Megan talked about, Medicaid pays crap, right? That's a technical finance term. And so it's really hard to cover that care. All right. So once again, it comes back to finances, right? When we were poor as a society, we did a lot of institutionalization. Those institutions were terrible, but that's all we could afford. We got richer and we said, that's terrible. We shouldn't do that anymore. We went too far to the other side with deinstitutionalization. Now we're coming back, but we're going to have other challenges in the future. All right. Thank you. Have a great weekend.